will say this doesn't have as much of a technology spin on it, but it is try to be the current state of PJI prevention. And no matter how good our technology is, I don't think we're going to be able to get rid of PJIs, but at least we can maybe implement some strategies to try to minimize them. Here are my disclosures. I do have a FAIR grant that we're doing a randomized trial on extended oral antibiotic prophylaxis, so that's probably pertinent. PJI prevention, I'm going to break it down into pre-op, intra-op, and post-op just because it organizes the talk better. But we have to recognize that this is a whole host of factors that have unique interplay. So this is not a single thing that we do in different things. All of these play together, the patient, the wound, the bacteria, what we do pre-op, what we do after surgery, and what we do during surgery to result in somebody's infectious risk. Preoperative strategies I'm going to touch on. Big take home is optimization is still king in my mind. These are the factors that I'm going to talk about in a little bit more detail, but I think that we should be focusing on pretty closely in our preoperative patients. Diabetes, we've known this for a long time. Increased risk of infection in a poorly controlled diabetic. And A1C, I think, is still the gold standard for measuring this, but some really good data out of Rothman looking at fructosamine. It may be more protective on periprosthetic joint infection risk and more reflective of glycemic control. And thankfully for us, it does respond quicker to treatment. But I would say the jury is still out on how well we're going to implement this and how broadly it's going to be adopted, but something that may be coming down the pipeline. Tobacco use, in my mind, I think this is a big one. I'm pretty adamant about tobacco cessation prior to surgery. It's strongly associated with wound complications and infections. There's a really good, people ask about, well, what's the data on actually quitting? There's a Lancet article in 2002 about electively quitting prior to total hip and knee arthroplasty only within 8 weeks. And these patients got better in terms of the reoperations and wound complications just by having the intervention.